Closures for this presentation. So, before we start off on any grossing any specimen, and not just the pancreas, we want to check the patient history, what the exact procedure is, what the indication is, any prior pathology, important to know if you have a prior diagnosis, was there any preoperative therapy, chemotherapy, or radiation, and any relevant radiology. So check your material. So look at the tissue that you've received, the specimen, does it correlate with the requisition and the specimen received? Check the operative notes. Was there any variation from the usual procedure, any unusual anatomy? And today we're talking about the pancreas. So was there just the main pancreatic duct? Was there maybe an accessory pancreatic duct? Was there any change in the normal procedure? All of those are important to look at before we actually start grossing the specimen. It's important to understand the anatomy before even touching the specimen and to formulate a grossing plan. Always check with the consultant or fellow if necessary. And there are a lot of things in pathology that we do where we can go back and make changes, but grossing is the one thing where it's irreversible. And so grossing is, before we make our first cut, it's important to have a plan. So the pancreas is a lobular gland located retroperitoneally. And so when we look at the anatomy of the pancreas, we have the head of the pancreas, which is the majority of the gland, and it is present to the left of the superior mesenteric vein and artery. And then this area is the neck, which is the thinnest portion of the gland. This is the portion that overlies the superior mesenteric vein and artery. And to the right of it, we have the body, and the tail extends to the hilum. The anterior surface is serosalized. The posterior is partially serosalized. There is no discrete capsule, of course. And when we look at the Vaterian system, so here we have the gallbladder, the cystic duct, hepatic duct, which join together to form the common bile duct. And the common bile duct joins the main pancreatic duct, and we have a dilation at that confluence called the ampulla. And the ampulla of Vater opens into the major duodenal papilla in the duodenum. And about 5 to 10% of the population have a minor or an accessory pancreatic duct, which tends to open in the minor pancreatic duct, which usually is superior to the major papilla. And it's important to know the location, because even before you look at the microscopy, you can get an idea of, you can narrow down your differential based on the location of the tumor and involvement of the duct system. So for example, ductal adenocarcinoma, the majority are in the head of the pancreas, Acinar, as is Acinar cell carcinoma. Mucinous cystic neoplasm and neuroendocrine tumors most often are in the body or tail. And serous cystadenoma and solid pseudopapillary neoplasm can be found anywhere. And also, depending on if the duct system is involved, then we can further narrow our differential. So here in this cartoon, we're seeing the major, the pancreatic duct, and here are the side branches of the pancreatic duct, if the duct system is involved. So when you're grossing the pancreas, it's important to identify if the tumor is arising from the duct system, involves the duct system. So does it involve the main pancreatic duct or the side duct? And you'll have this information with the radiology as well. So these are all pertinent details to understand before we gross the specimen. Serous cystadenoma and mucinous cystic neoplasms do not involve the duct system. And IPMN, or intraductal papillary neoplasm, can involve either the main duct or the side duct. Sometimes it's mixed. So the common pancreatic resection types that we deal with are distal pancreatectomy specimen, which is a partial pancreatectomy, and the Whipple resection. There's a classic type which involves a partial gastrectomy, partial duodenectomy, the head of the pancreas, sometimes includes the gallbladder, and these days the pylorus preserving Whipple is preferred. So the distal pancreatectomy is a resection of the pancreatic tail, sometimes part of the body as well, and it usually includes the spleen. Sometimes there is transverse colon or stomach associated with the specimen. And the main margins that we're thinking about are the proximal parenchymal resection margin, which includes the pancreatic duct, and soft tissue margins or surfaces. So remember, we said that the posterior is not serosalized, so that is a true margin, and whereas the anterior surface is serosalized, so it's considered a surface. And depending on the institution where you're at, and depending on your surgeons and oncologists, these soft tissue margins or surfaces may be important. So check with your clinical colleagues before deciding if that is a margin or surface that you're interested in. The parenchymal resection margin is taken en face or perpendicular depending on the distance to the tumor. Generally, if it is within a centimeter of the margin, we take perpendicular sections. If it is further than that, an en face section is adequate. And we section perpendicular to the long axis. Note the size of the tumor and distance to the soft tissue margins or surfaces. If there is a splenic vein present, look for involvement by the tumor, evaluation for thrombosis. And if it is a cystic lesion, generally, if it is less than 5 centimeters, we want to submit it entirely. And this is because cystic lesions can be associated with an invasive adenocarcinoma component. And so in order to not miss that, we want to evaluate it entirely. And of particular note is solid or indurated areas in the cyst wall. These should be submitted as well. If it is greater than 5 centimeters, then we want to submit at least one section per centimeter of the tumor. So the Whipple resection, like we said, there's the classic and the pylorus preserving Whipple. So this is what the resection involves. So we have the head of the pancreas, sometimes with the gallbladder and bile duct and the duodenum. Sometimes the distal margin includes the jejunum as well. And post-resection, the anastomosis is all the remaining bits and pieces are connected to the small bowel. So in front here, we have the stomach, which is connected to the duodenum, pancreas into the duodenum, and the bile duct also directly into the bowel. So we have many margins and surfaces of a Whipple specimen. So the most important ones are shown in this cartoon here. So we have in green, we have the bile duct margin. Here in yellow, we have the pancreatic neck or the pancreatic duct margin. And here we have the uncinate margin. And we have the intestinal margins, which are the proximal and the distal. And sometimes you have a proximal gastric, and sometimes you might have a distal jejunal as opposed to a duodenal. And these margins are different depending on what protocol you use. So the American Joint Cancer Society considers all of these as margins. The College of American Pathology also considers this as margins, and that's what we practice in our institutions as well. And this is pretty much common in most places. Now, the trouble comes with the other margins, or surfaces, which is the vascular groove or vascular bed, the anterior surface and posterior surface. At my institution at the University of Washington, we consider all of these surfaces and not really true margins. And if you look at the AJCC guidelines, the posterior is considered a margin, and the CAP considers them surfaces. So again, check with your surgeons and oncologists to see if these surfaces are treated as margins or not. So this is a useful way to help orient the Whipple specimen. You can use your left hand to orient the anterior view of the pancreas. So the bulk of it would be the head of the pancreas, the thumb would form the uncinate process, And this groove between the thumb and the rest of your fingers would be where the vascular groove is, where the superior mesenteric vein and artery would be, and the remaining fingers would be the neck, body, and tail. So this is a useful way to orient when for the anterior surface of the pancreas. The other way to do this is the trapezoid method. So this is the trapezoid here, highlighted in the yellow ink. So this is the posteromedial side of the pancreas. So when you get the specimen and in a fresh state, identifying the anterior and the posterior, and on the posteromedial side, the easiest a landmark to identify is the vascular groove, because it is smooth and serosalized, and it's easier to identify. And the smaller cauterized area is usually going to be your pancreatic neck, and the larger cauterized area, which is more ragged, is going to be the uncinate margin. And so this slightly concave vascular groove is the first thing that is easiest to identify. And then once you identify that, the pancreatic neck and the uncinate is easier to identify. And once these are identified, ink these margins. The anterior surface is more convex, irregular, and has more fat. The posterior surface is flat, and these surfaces are inked as well, depending on whether you want to treat them as margins or not. Irrespective of that, it's easier to orient once the specimen is fixed and formalin. So these are useful to ink. So here is the pancreatic duct on the left side of the trapezoid. And the common bile duct is usually larger, and most often, because of obstruction by the tumor, it is dilated and easier to identify. And sometimes you might have a stent for palliation of jaundice. So, and if your institution does tumor banking, you might have to superficially sample for tumor at the very beginning, and also make note if the margins were already assessed during frozen section evaluation. And so the first thing we do after orientation and inking is to remove the margins first before opening up the specimen. So the proximal and distal representative en face, because they usually tend to be further from the tumor. The CBD margin is taken entirely en face. The pancreatic neck margin is again entire en face. The uncinate margin is taken as a chunky en face, so at least a 1 to 2 centimeter thickness. And once this section is taken, then it is bread loaf. So you essentially get perpendicular sections. And the reason that we want to do this uncinate margin as a chunky en face is because in the fat we have lymphatics, and these lymphatics are not so easily accessed with imaging. So when there is involvement of the lymphatics, the imaging is not able to pick that up. And so we want to make sure that we sample all of the fatty areas to look for metastatic involvement. So then we go on to opening up the specimen after taking the margins. So the common bile duct and the pancreatic duct are probed, 2 separate probes, and we bisect it along the duct system. And sometimes it's easier to go through the ampulla rather than go through the duodenum. So in case you get stuck, if there's obstruction by the tumor, then another way to try and probe is through going backwards through the ampulla. And here, this probe, in this picture here, we're seeing a minor papilla here with an accessory duct opening. And so examination of the ampulla is very important, because the location of the tumor, whether it's a pancreatic head involving the ampulla or more of a duodenal or ampullary neoplasm, is important because the staging protocol that we use is going to be different. So examination of the ampulla and deciding on gross where exactly the burden of disease is very important. And sometimes we may not be able to tell, and that's okay, but we need to make an effort to find out exactly where the primary is arising from. And then we can, at this point, you could remove the peripancreatic fat to peel off the fat, and then you could bivalve the pancreas along the duct system through your probes. Another way is to axially section, like we do with the distal pancreatectomy, perpendicular to the long axis. But generally, when you bivalve the pancreas and sort of fillet it open like a book, that is when you'd be able to assess the involvement of the different structures. And then, so as you angle your knife along and let the probe guide the direction of the cut and keep checking, you can do small cuts, keep checking with every cut to stay within the plane of that cut. And so at this point is when you would fix the specimen. When you bivalve it, it allows the formalin to seep into all these areas, and it is best to fix it at this point. So here is an example of a specimen that has been bivalved. So here we have a bile duct that is dilated. Here is the pancreatic duct. Sometimes it's useful to ink these differentially, to ink the mucosa, and this is not for purposes of assessment of margins, but just for orientation. And on microscopy, sometimes it can be difficult to distinguish between the bile duct and the pancreatic duct. So differentially inking the lumen of the bile duct and the pancreatic duct can be helpful. And here you see that the ampulla opens up into the major duodenal papilla here. And so how much of the tumor to submit? And generally, if it is a small enough tumor, 3 centimeters or less, then it's possible to submit the tumor entirely. But otherwise, generally, we want to section it so that we get an accurate microscopic span of the tumor. And this is because the T staging is dependent on size. And often these days we get pancreatic specimens status post neoadjuvant therapy. And depending on the amount of residual carcinoma that we have, the T staging can vary quite a bit. So because of this, of the importance of size here for staging, it is important to get a microscopic scan. And so consecutive mapping sections are recommended. So it is not, we previously used, just even a couple of years ago, we used to do this as a gross estimate. So you're getting really a tumor bed size and not really viable or residual carcinoma size. But we want to, get mapping sections. So you take a negative bracket, maybe a section where you see that there's grossly no involvement, and serial sections. You don't need to submit all of these sections. You could submit maybe every alternate section. And the size is determined based on the microscopy. So we discussed all of these. So the sections that we need to submit would be the proximal distal margins, the bile duct margin, pancreatic neck, the uncinate, and relationship of the mass to the ampulla, CBD, the anterior-posterior surfaces, and the entire tumor span or alternative tumor slices, uninvolved pancreas, and the lymph nodes, peripancreatic and perigastric, or if there is perisplenic as well. Okay, so that was all about the grossing. So now let's go on to histology of the pancreas. So the exocrine pancreas, so the pancreas is both an exocrine and an endocrine organ. So the exocrine component is the majority of the gland. It comprises about 80% of the gland, and it is a tubulo-alveolar gland. So we have acini that produce the pancreatic enzymes. We have the duct system that carries the secretions and dumps it into the duodenum. And then we have the supporting mesenchyme or the connective tissue. The pancreas doesn't have a capsule, and it's separated into lobules, and we have this intervening fibrous and connective tissue septa. And we have the interlobular ducts, which are ducts that carry secretions from the larger lobules, and they are identified by a thick collagen layer. and we have the intralobular and the intercalated ducts, which are smaller, and you identify them because of the lack of a collagen layer. And the acini blend into the surrounding fat. Sometimes you might find sort of these islands of pancreatic acini out in the fat, and that's all part of the normal histology. And there's acinar atrophy with age. There's more fat with increasing age and the nutritional status, and depending on a duct obstruction. So here's a close-up view. Here we have a duct highlighted by the blue arrow, and you see that it doesn't really have too much collagen around it. So this is an intercalated duct. And then surrounding it, we have the acini. The acini are deeply basophilic because of all of the rough endoplasmic reticulum, and it has abundant secretory granules filled with trypsin, chymotrypsin, and lipolytic enzymes. Here we have a picture of the endocrine pancreas. And the endocrine pancreas, the composition depends on the age. It's usually between less than 5% in adults and about 20 to 30% in neonates. And it can be compactly arranged as these islands of endocrine cells, or it can be more diffuse and sort of infiltrative appearing. And most of, in adult pancreata, it's mostly compact distribution. And the majority of the cells that compose these islets are beta cells, which secrete insulin. They're usually found in the more centrally located. The alpha cells, which secrete glucagon, are more peripherally located, and the other cells are delta cells, the pancreatic polypeptide cells. We also have some gastrin-producing cells, but the major cells are the beta cells, which secrete insulin. So here's a more close-up view, and then we see the typical neuroendocrine chromatin, where you have the salt and pepper chromatin pattern. It's very monomorphic, and we see that it has a prominent capillary network around it because there is no duct system to carry the secretions of these, since they're hormones and they are dumped directly into the circulation. So let me just show you a slide. And we'll go through the histology again on the virtual slide. Okay, do you see it now?
Yes, perfect. Thank you.
Okay. So here we see a section of the pancreas, and this is a really nice section because here you can see on the right side, this is normal architecture of the pancreas, and on the left side, there's disruption of the architecture. And here we see a muscle, the muscularis propria of the duodenum here, and this is the pancreatic duct. So let's look at the pancreas here. So the normal architecture is, this is the lobular architecture, where we have these lobules that are differentiated by these fibrous septa, and we have surrounding adipose tissue. There is no capsule, and the amount of adipose tissue increases with age. And here, at this low power here, you can see these larger ducts, and they have a collagen layer around them. So these are the larger ducts. So both the main pancreatic duct and the interlobular ducts have this collagen layer. So when we take a closer look at this, this duct right here, so this is one of the larger ducts, and it's lined by a columnar epithelium, and we have, it's a mucinous epithelium, and we have nice orderly nuclei and a prominent collagen layer. And then when you compare it with this duct right here, so this duct here, this is an intercalated duct, and this does not have mucinous cytoplasm, this does not have a collagen layer, so this is the smallest units of the duct system. So here you can see that we have nice orderly arrangement of the nuclei, no mucinous cytoplasm in the smaller ducts. And then when you take a closer look at the acini, which produce the pancreatic secretions, you can see that it has secretory granules. It has a somewhat of a triangular profile with basally located nuclei and luminal secretions. And let's identify some islets. Islets stand out because they are pale, and you might see both compact and infiltrative types. So here is a more compact arrangement. We have fat, we have vessels, and here is a nerve bundle. So the neurovascular structures are present in the connective tissue septa. And so, so here we can appreciate this nice organized architecture. And then on the other hand, when you come over to the other side, here carcinoma, pancreatic ductal adenocarcinoma, this is a classic one. This is characterized by a lack of lobular architecture. And when you look at the cytology of these cells, even though the cytology is not so, it is not very high grade, it is the architecture that really tells us that this is a carcinoma.